All right. First, let me say welcome and thank you for attending today's webinar. My name is Mark Pagliata, and I am the Director of Commercial Operations here at Sonoscanner US. And today we have a great webinar by Dr. Ian Ko. Dr. Ian Ko is an internist from the University of Arizona, Banner Health. And I'll be turning things over to him in just a moment here to bring you this great webinar, The Role of POCUS in Sound Patient Management from, of course, his perspective. I would like to speak for a few moments about Sonoscanner. For those who are not familiar with Sonoscanner, Sonoscanner, the company, has been around for over 23 years, and certainly what we're known for is French ingenuity, but also with clinical know-how. Our founders have brought that to the table for many years now. Uh, as we've developed our products through the years, we've kept the clinician in mind, always for a few different things. Ease of use, the product has to be very easy to use, but with the highest image quality. Something that's been kept in mind, whether it's some of our console-based ultrasound devices, or more recently in our ultra portable devices, the U-Lite Pro and the T-Lite Pro. These small portable, ultra portable products have really been a great advancement in imaging in recent years. The U-Lite Pro, which you see there on the right-hand side, this is a premium handheld ultrasound scanner with lots of flexibility. Whether it's the U-Lite Pro or the T-Lite Pro, which I'll introduce to you in just a moment here, we have 11 different transducers for the device. So it makes it quite flexible from its scanning capabilities with all those different transducers. From a software perspective, we have lots of different applications to help with the different workflows that the customer might be working through. Whether you're an internist or in emergency medicine, specializing in MSK, urology, et cetera, et cetera. We have applications which can help with the workflow that you're most accustomed to. And we'll customize the device to really meet your workflow as you need it, whether it's in the form of an application, presets, comments, etc., or even developing the product configuration for you too. The product is very flexible. What's nice is that you might start off with a certain application or a certain probe, and you might tell us months down the road, I'd like to expand my capabilities, and certainly you can do that with our devices. We allow you to upgrade and add on to the device as you expand your horizons. Innovation, what a key part of our systems. In the most recent 2 years, we've been introducing AI into the product, integrating it to optimize your scanning capabilities and decision-making process. All Doppler modes are available on these very small tablet-based ultrasound devices, considering color Doppler, power, pulse wave, and color. These devices, although they're very small, again, very powerful, and something that we've been known for through the years. Before I turn it over to Dr. Ko in just a second here, I would like to mention that at the conclusion of the webinar today, please be on the lookout on your email. We've got something interesting that will be coming your way via that email. So give it a look a little bit later on. And again, we appreciate your attendance today. You are able to ask questions in the Zoom question and answer screen. At the bottom of your Zoom screen, you'll see 3 buttons right next to each other, 3 little dots. You can click on that and you can bring up the question and answer window, and that's how you'll be able to ask us questions. And at the end of the webinar today, we've reserved some time to do just that. We'll answer the questions, or Dr. Ko will be nice enough to answer those questions for us. All right, with no further ado, let me stop sharing here. We'll give the opportunity to hand it over to Dr. Ko, and let's begin our presentation.
All right, let me see if I can get this set up here. Can everyone hear me okay? Mark, can you still hear me okay, Mark?
Yes, we can.
Got it. Yeah, everything's blooming out here, so everyone's getting allergies. So thank you all for coming. Yep, I'm Ian Coe. I'm out here at University of Arizona. I'm a hospitalist. Um, I came out here to do and I came out here from Georgia about 5 years ago to do an ultrasound fellowship through the emergency department here, and then I've stayed ever since. So I want to make clear that the views and especially corny jokes expressed by me have or in no way reflect the views of Sonos Scanner. So let's get started here. So this is not my image. This is a famous image online. Neelam Sawhney, one of the kind of godfathers of internal medicine ultrasound, it was telling me recently the source for this, and then I looked it up and I forgot the link. The quote at the bottom, however, the modified quote is mine, courtesy of Shakespeare. So a little bit about me. I was born very young, as Groucho Marx says. It was all hands on deck back then. Everyone was thrown into a call schedule. All I had is it was a stethoscope at the time. Then I grew up, came out to the ultrasound fellowship here. I really grew up. That's me. I'm usually the tallest in the room. This was actually my mentorial fellowship director, Srikar Adhikari, out here at University of Arizona. He's internal medicine, also mainly internal medicine EM trained as well. Now just does emergency medicine. And this was his mentor, Michael Blavis, who was a real pioneer with ultrasound. He's an emergency medicine physician, also an engineer. And so that this was a picture near and dear to my heart. So I have uh, yeah, so overview. So kind of just an intro to ultrasound in general. I tend to go over time, so I'm gonna, some slides, I may have to really blow through them. If we have to skip some slides, I will make sure that at least the PDF gets sent out for anyone interested. There's probably a spectrum of people, some with lots of experience in ultrasound, some with no experience, some with interest, at least. So at the very least, if you have no interest or if you're very experienced and this makes you bored, I have been told I do very good at putting people to sleep. My record is about 5 minutes for a resident to start falling asleep through a lecture. So, um, yeah, so unfortunately, I do have no conflicts of interest. Yes. So, and there's a picture. I actually met Mark several years ago at AIUM, or I think it was either in Orlando or Austin, I guess. And this was last year, I guess, in Orlando. And this is Etienne, whose father started the Sonos scanner, the company, and now he has taken over the helm. So he's over in France. I don't know if he's on or not, but I want to thank Sonos Scanner and Mark, and then Jean, who's in the background making all this happen on the technical end. Really want to appreciate, thank you for this. This is my first webinar I've ever given. Usually I'm presenting in front of a live audience so I can see if my jokes are actually falling flat or not. So just bear with me. So just a few quotes here. Some of these are a little dated, but several I'd like to point out. So that I think the NASA endorsement on ultrasound, fastest, safest, most universal diagnostic method, or amongst one of those, that's got to be one of the best reviews you can get. Um, and then some of these are a little dated, like Eric Topol. Everyone knows he's a kind of a celebrity cardiologist who's done excellent academically and also has done a lot of engaging the public on medicine. But one thing I think hasn't aged well. He said this. He said it will replace the stethoscope. I think he had said in the next 10 years, and that was like 12 years ago. So, and we'll get into that maybe a little more later. I don't think ultrasound can definitely augment what we do. Um, um, but the one thing that no imaging, including ultrasound, can't do that a stethoscope can do is detect wheezes. So hence we like to call the stethoscope these days the very least, the wheeze detector. So yeah, never treat family, or the title for this slide was actually going to be like medicine begins at home. This is actually me with various cousins actually using ultrasound because they had various ailments, whatever, anywhere from pediatrics, little guy, all the way up to adults. So Benefits of ultrasound. So yes, it can improve patient safety, patient satisfaction even. We had one patient at one of our campuses where especially there was a lot of poverty, a lot of poor access to care, and he came in and we were scanning along with several of the students and residents and kind of doing whole body scanning on him. And he said at one point, he said, "Are all poor people treated this well here at this hospital?" And it really struck me because yes, we put a lot of effort into helping everyone, regardless of ability to pay, et cetera, with the vows we took in med school. But um, they often don't see that. It's behind the screen. And it's kind of behind the scenes. We're spending a lot of time with computers. We went into medicine to actually be at the bedside. And the thing about point of care ultrasound is it forces you to be at the bedside. Also allows for precision medicine. There's a lot of sort of hand waving of a lot of things we do, especially with things like volume status with patients. And it allows you to actually, really get in there and really challenge some preconceptions we have even about physiology. So some applications already existed. A lot of what we did is we took complete scans, full scans, and we said, okay, what are the most important things we need to answer very specific questions in ultrasound? Lung ultrasound in particular is one that actually arose at the bedside. It was originally said, even within the past 20 years in Harrison's medicine, that lung ultrasound just doesn't work because air obliterates the beam. And it turns out that even as far back as the late 1970s, Daniel Lichtenstein over in France said that turns out that's we can actually leverage ultrasound even for the lung. So also reduces burnout. One of the main reasons we went into medicine is to be at the bedside, and as we had said, it really forces you to be at the bedside and just kind of really ignites your curiosity. And really informs and, like we said, can challenge some preconceptions about physiology, some of which are really being developed in the literature. Um, and especially, if you're in the mission field, it's really a force multiplier for, especially in an austere environment. Um, I've even seen this, even not even in a third world country, but even in our own nation. I sometimes when I go home, especially or out here, there's patients who are just really they don't have very good access, mainly because of financial limitations, and sometimes an ultrasound can be in the hundreds of dollars. So if we're able to do this ourselves, um, uh, that this can really get medical care to a lot more people otherwise. Yeah, so again, just like it requires you to be bedside, shoulder to shoulder with the patient, it has really improved my teaching, I think. And because it's something that, yes, while part of ultrasound teaching is didactic, really the core of ultrasound teaching, it's not rocket science. It takes reps and reps and miles of skin being scanned. And you've got to do that shoulder to shoulder with patients. So this is one of my favorite pictures, actually from residency, working on putting an IV in a tofu model. So yeah, so memes. This is one of the favorite memes on all. This is unfortunately I didn't make this one. Um, yeah. So in general, there's a busy slide, but there's this kind of breaks down some of the applications for each specialty. In general, in summary, internal medicine uses pretty much full body ultrasound, but some of these you wouldn't expect would be, for instance, palliative care. Now, how would palliative care be using ultrasound? Well, it's something we've actually been toying around with the idea of maybe doing palliative drainage for patients, for instance, with end-stage cirrhosis or peritoneal carcinomatosis with lots of ascites. It gets very uncomfortable. Patients with malignant effusions. Sometimes you can get pleurexes in them, but sometimes it happens relatively quickly. And or if you're a place where you can't do a pleurex drain for someone, I think this could help. Also for the geriatric population, there's more literature coming out about how can we bring the hospital to them. So for instance, house calls are starting to be resurrected in some areas of the country. And, for when you have someone they do, especially a geriatric patient, movement limitations, otherwise, or you just don't want to throw off the routine. If you can take an imaging suite to them, you may be able to prevent them from having to come in, even in the clinic or at least to a busy hospital and getting delirious in the ER, et cetera. So, uh, okay, so the vast majority of evidence for point of care ultrasound has come from the emergency medicine and critical care literature. And the United States is relatively new to the field. new to kind of jump on the bandwagon. Um, one of the probably the first real adopter and champion in the United States was Michael Blavis, back, 20, 30 years ago almost. So it was really started to be adopted in emergency medicine in the kind of in the 90s, early 2000s, and then really became mainstream by say 2010. It was very mainstream and adopted and protocolized in emergency medicine. Internal medicine has been relatively slow to adopt it officially, but there are some guidelines from some of our main societies, American College of Physicians, Society of Hospital Medicine. So as far as what will you do, this is again the title of the presentation, bring it to as a tool in your toolbox. So what can you use it for? So these are some syndromes that we see, if not on a daily basis, several times a week. And there are many things, even you might see in the GYN sector, you have someone, that has vaginal bleeding. You can get on, we've diagnosed several like fibroids. We've diagnosed just on the internal medicine side, in concert with OB, we've diagnosed several like, threatened abortions, missed abortions. Some of this is critical care based, but the vast majority of this I actually see on a daily basis. So guiding principles, ultrasound must be used in the context of the entire clinical picture. Um, so any image itself will not make the diagnosis for you. There are caveats, and you must integrate it with the entire clinical picture, all the data you have. Also, know your limitations, and we'll get into this a little more. Extension of the physical exam versus, versus is this actually just a separate modality of imaging? So POCUS, point of care. First, I do not like that term, that acronym, but it's here to stay, unfortunately. It sounds kind of like a cheesy acronym, but it represents a concept. So, but point of care ultrasound, what it can do, it can answer specific questions using limited, usually just limited exams, specific questions about organ system. For instance, is there fluid present? Is there not fluid present? Is the fluid where it's supposed to be? Is it around the heart? Is there not enough in the heart, or the vasculature? It can reduce time to diagnosis. This was one of the main things that helped them to adopt it in the emergency department years ago. They said, we can really improve length of stay if we don't have to wait for a sonographer to get in to scan a gallbladder. If they come in at 2 a.m., we don't have to wait till the sonographer gets here at 6 a.m. We can do it ourselves. Um, so especially if you're deciding, do I send this person in from clinic? Do I send them out to, this person who has a hard time even getting to clinic every 6 months? Do I send them to get, a DVT ultrasound if they have leg swelling? Do I transfer from a small hospital? So way out in Yuma, Arizona, do I have to transfer someone for like 3 hours, or or do they have time to just follow up with their cardiologist in town, um, and I can send them home? So what it cannot do, cannot think for you. Abhilash Koratala, the nephropocus, he's excellent nephrology critical care doc who's really moving ultrasound along in the United States. He likes to say, yes, it can't think for you, it can't interpret itself. So this saying, a fool with a tool is still a fool. So you have to know, how are you going to use it? Um, and this, we'll get to this later on, but especially in cardiac arrest, once again, the only thing that improves, well, the main thing that improves mortality in cardiac arrest would be chest compressions, not extending your pulse check time just to use the ultrasound to take a look at the heart. We'll try and get into that a little later. Again, it cannot replace a complete study. So know your limitations, know what POCUS is designed to do, and then you can do consultative ultrasound to consult radiology or cardiology for a complete scan. So okay, so the first application, I actually just added this in the other day. Um, so I think internal jugular vein. This is just such an intuitive application for ultrasound. And what's surprising is that it's taken a while to just become mainstream. It's been known. It's only in the past 4 or 5 years that it's really shown up a lot in the literature. So it's so intuitive because this is something that is hammered. So one of the most hammered concepts in medical training is assessing JVD, and estimating right atrial pressure. It's one of the first things taught in internal medicine residency, at the very least, to teach someone how to do an IJ central line. You find the IJ and and look around for structures. So this is a relatively high yield application. It's been shown, there's some literature coming out showing that it takes minimal training to deploy this. So what you're doing here, you're finding your IJ carotid. Here's a relatively collapsed IJ, i.e. diameter is less than that of the carotid. This is a very large IJ. One view is no view in any imaging. So this is showing in longitudinal axis. You would say the jugular venous distension point ends right here where that IJ is collapsing. You see these walls from a dilated IJ coming together at this point. So Larry Istriel has really done a lot in this field. This is his story. This is actually made in the American Society of Cardiac Echo, JACE journal several years ago. But if you even just Google ultrasound JVD, you'll see a lot of stuff come up. He has a great blog on it that he's incorporated it into a new textbook he just came out with. So this was actually, so here is a patient we had come in. You'll see his lung later on. Um, Very large dilated IJ here is dilated up to the angle of the jaw. You can actually see the X and Y descent here. You can see the jugular venous pulsations kind of visually just with that spontaneous contrast here. This means that there's this very poor flow, significant congestion. He had heart failure, reduced ejection fraction. At first, this was interesting because we thought this spontaneous contrast usually means sluggish flow. But there was something flicking in and out of the screen, and it looked like it was congealing around here. He had recently been in the hospital, and we didn't know if he'd had a central line or not, which can sometimes give you a jugular vein thrombosis. But interrogating the whole jugular vein, it turns out it was just sluggish flow. This right here is actually a valve, which can be a normal variant in the IJ. And it was just kind of, just slow flow around here. Looking in long axis, you can see there is no clots around this valve. Next application, lung. Probably spend the longest amount of time on this application. This one, as we said, arose at the bedside. Daniel Lichtenstein, who actually is very particular about the ultrasounds he uses. And fun fact for this presentation, I'm told that Sonoscanner is, if not one of the few, if not the only handheld he actually likes to use. Either whether he's in the hospital or like deployed on a helicopter somewhere. He does all sorts of medicine everywhere. The lung evidence, this slide is like from 5 years ago, but the idea still stands. So the amount of lung ultrasound publications doubled within 6 months of COVID. COVID caused a lot of challenges. It also gave a lot of opportunities to deploy ultrasound. So guidelines here, making it in the mainstream of guidelines. So this was actually the first focus guideline that American College of Physicians released supporting ultrasound use, and it was using ultrasound in acute dyspnea. This was about 5 years ago now. And then last year, with the updated community-acquired pneumonia guidelines, the first question they addressed for this update was the use of ultrasound as an alternative to chest X-ray. And our very own Neelam Sani, who's kind of the godfather of internal medicine and point-of-care ultrasound in the United States, he was just the fourth author on this. It shows how significant lung ultrasound was in this guideline. So it's nice to see the guidelines from the mainstream really supporting this is actually helping give society backing to employing ultrasound in different institutions. So it's even mentioned lung ultrasound and mentioned in the major cardiology journals. We have JACC, JACE, and this is 5 years ago. This is actually Daniel Lichtenstein, ultrasound godfather. This is the French Society of Echocardiography, I think. Lung ultrasound versus chest X-ray. Often you'll hear that lung ultrasound is more sensitive than chest X-ray. Yes, it can be. But again, whereas the chest X-ray sees the whole chest in one shot, ultrasound is just where you point it. One thing the ultrasound can do is characterize effusions. This is one of the few areas where it can actually give you more information than a CT, because whereas a CT, the effusion will just look like a big white blob, the ultrasound can actually penetrate through and can at the bedside and just take a look to see, are there septations here? Is there a bunch of particulate matter floating around? We'll see a few of those later. So most common uses for lung ultrasound is respiratory failure. Is this pulmonary edema? Is there a big effusion there? Is this more of an ARDS picture, inflammatory pneumonia picture, or is there a pneumothorax? Is the lung even inflated? It can help with heart failure diuretic assessment. It's becoming bigger and bigger actually in cardiology in the setting of stress echo. During stress echo, now some people are actually doing lung ultrasound to see, if you have high left atrial pressure, is that or diastolic dysfunction, is that translating to are you getting pulmonary edema during this stress echo? Um, so scanning protocols, this is from one of the original, the blue protocol from Danny Lichtenstein. In general, people divide the chest into upper, lower, anterior, upper, lower, lateral, and then there's some posterior views. Some people do a lawnmower approach, going through all the different rib spaces. This is especially important if you have something like COVID, for instance. This was actually from a COVID paper on full body ultrasound. And then there are some scoring systems out there as well. This is, I think, from an Italian hospital. So, first case, this was a 38-year-old man, IV drug use, presented with fever, productive cough, sweats, dyspnea. He'd been homeless for a few weeks. So, this could have been anything. So here was the actual X-ray on him, and this was during COVID. It was like 2020 during COVID. So this was quite impressed to actually see instead of these diffuse infiltrates like in COVID, we actually saw an honest to gosh translobar pneumonia. So the ultrasound on this is showing this is right around the right middle lobe here. What we're seeing is consolidation. The air bronchograms, which just means air caught in small airways surrounded by consolidation. So you'll see air bronchograms in all imaging, X-ray, CT. But what you can see with ultrasound, since it's dynamic, is you'll see that not only just air trapped in the bronchi, but you see the column over here. These are actually bubbles moving in and out. So this is a very specific sign for, because atelectasis can do this. It can cause there's air bronchograms and compression of the lung, but we found out that it turns out when you see these dynamic air bronchograms, that means, so whereas in atelectasis, where the airways are kind of collapsed, either from a mucus plug from above or compressive atelectasis from down below, this is more indicative of a consolidation around those airways, and there is a connection between the lower and upper airways. So, this was a neat case. See here. And also on here, what we're seeing is if you put color on there, I know there's a lot of scatter here because we didn't have him breath hold in the setting of a little bit of respiratory distress. But we are seeing if this were an infarct, first of all, it would have been a heck of an infarct. But we would see no evidence of vascular vessels, whereas right here we're actually seeing the vessels light up under color. So this is more indicative of an actual consolidation. Okay, so next patient, he was a 61-year-old man. He has a history of HFrEF. That was actually his IJ we saw a few slides back. COPD, presented with 3 days of cough and chest and back pain. Originally it was chest pain. Turns out it was very localized. It was to his right flank and kind of radiated around. It was around the costal margin. So he had just come in about a month before with a severe pneumonia. So they got this X-ray. It looked relatively clear. Maybe some hilar involvement here, but more than likely it could have just been it was resolution from his previous pneumonia. And they didn't want to do a CT on this guy because the question is always, is this just COPD exacerbation? Is it a new pneumonia? Heart failure? So we see it doesn't look like he has significant pulmonary edema here. So although he does have heart failure, didn't look like congestion was really leading, maybe a little bit of congestion here, but however, we put an ultrasound probe. It was actually right over the area in the back flank where he was having this chest pain. It's very pleuritic, and we saw this was a consolidation. And looking back on his CT from previous, it was not, he did not have any infiltrates in this area of the lung. So we said, okay, this is likely new pneumonia. We started him on antibiotics. He felt great within a few days, and then we got him out. So pleural effusions. This is a simple effusion. What we're seeing here is feet this way. This is the diaphragm, head this way, so lung up here. So diaphragm. This is likely liver here, and then you can see the lung here kind of floating in the tissue. They call this the jellyfish sign. One inventive person was actually on a trip down, I think, to Bahamas or Australia or somewhere, and they're doing some veterinary work with jellyfish. And he had an ultrasound. He said, "Oh, what if I put an ultrasound on this jellyfish? I wonder if it actually looks like the jellyfish sign." And it turns out it does. That image was on Twitter, and I've been kicking myself for years because I didn't save it. So next patient, she was a 73-year-old woman. She had a history of AFib and a leaky valve, but no known history of heart failure. Came in with, she'd had swelling for the past 10 years, but she had had some breast cancer and there was chemo. Yeah, so they thought, well, maybe she'd had the swelling after that, no heart failure. They didn't know if chemo had anything to do with it. But regardless, she comes in with chest pain, kind of shortness, more shortness of breath picture. She had literally walked into a house fire when she got home and tried to gather some stuff up, came out, got significant carbon monoxide exposure. Her carboxyhemoglobin was 14% when she got here. Um, but by the time I'd seen her, she had gotten a lot better. So here's her X-ray. Significant congestion we're seeing here. No obvious infiltrate. You notice we're not seeing an obvious effusion, a little blunting, maybe the costophrenic angle here, but however, ultrasound helped us out here. This is see significant B lines here. This is indicating significant thickening or infiltration of that subpleural interstitial tissue, whether that, and in this case, it was likely from pulmonary edema. It was diffusely like this in all the lung fields. And then you could see a little bit of an effusion on each side as well. So she so we thought this was either direct toxic injury to the lung. Turns out she did maybe have some diastolic dysfunction as well. So I think we kind of unearthed some heart failure, and we were able to diurese her, get her out within several days. So this is a similar patient. So, well, a similar area we're scanning, different patient altogether. Is a 70-year-old man, had a history of non-small cell lung carcinoma. We didn't know at the time, but he had had a recent CT. It showed he'd had Mets and pretty much filling up about 75% of the lung volume. And he came, it looked like, and he came in with just worsening hypoxia, shortness of breath for the past 3 days. Um, and uh, and maybe it had a PE in the past. So we're trying to figure out what could this be. So just looking over on this was the left lower area, and we saw it looked like a consolidation. He had a little bit of cough, but he'd always been having cough, and a little bit of fevers, but he'd had that for months in the setting of these significant metastatic burden. So turns out. And this looked relatively, we say, this doesn't quite look like just a consolidated lung with, I mean, yes, these are bronchograms, but it looked a little, in other images, looked a little kind of sludgy also. So we got the CT, and unfortunately, this is just the lungs were just eaten up, as they say, with Mets, and this was right around the area where we were scanning, and so that was actually, we think, just metastatic burden. So grew up on a farm. You'll see my handle is Ranch Doc on Twitter, just for my roots. But this is actually, you can use ultrasound for animals too. So this was just one of our first patients on the farm, and she was not thrilled to be offered the most scientific and up-to-date veterinary medicine. So next, and I'm gonna have to move a little faster here, I think. So the next application, cardiac POCUS. This is probably the one, along with lung, that we use the most in the hospital. What can it do? Well, it's limited. We ask a limited number of questions. Is the very good systolic function? Is it poor systolic function? Is the right heart blown out really under stress in the setting of a concern about a PE or not? And so what it can't do, it can't give a complete exam. Complex valvular device assessment. Even those who have taken the critical care echo boards and do more advanced echocardiography, sometimes it's even with the complex valvular assessment, if sometimes you just need a nicer machine too. And a lot of the POCUS machines we use are relatively smaller. But always remember, know your limitations and consult echocardiography for any odd findings that you can't explain or complete exam. So, but I would argue wall motion abnormality should not necessarily be in the purview of point of care ultrasound. If you see it, great. But even cardiologists, they've um, seen that sometimes there's a coin flip, especially with relatively minor mild wall motion abnormality, whether they agree. And then strain echocardiography, while some of the machines can do this, there's so much variation even between, say, some of the big machines that cardiology uses that that hasn't been validated yet for a point of care machine. So here's some of the guidelines. You'll notice one of the earliest ones was back in 2009, all the way back then, and this was a handheld study. That was very early in the handheld environment, but we got some articles from SHM on here. So there's a preponderance of evidence again in the EM and critical care literature, less so on the internal medicine side, but it's developing. So these basic applications looking, we can send this out later because we're going to have to go a little faster here. This was not my image, unfortunately. This was posted on Valentine's Day years ago. So One of the most, one of those common things we come across in the hospital, even in the clinic, short of breath, dyspnea, leg swelling, do they have heart failure? And really quick look, this was one patient we had, 40-year-old man came in. He has a history of heart failure, didn't know if it was a preserved or reduced EF. He came in with chest pain and dyspnea. So here's his heart, this peristernal view. This left ventricle is not pumping very well. Um, See over in this short axis, you just see how it is not pumping very well at all. We're also seeing a little bit of a pericardial effusion, a little bit of a pleural effusion as well here. This was a patient who had come in, a 63-year-old woman. She had a history of coronary disease. She did have a known history of HFrEF with an AICD, but also the COPD, diabetes, CKD, et cetera. She came in with leg swelling and dyspnea. Um, Looking, you can also see, yes, we confirm she still has reduced EF, but also we saw this, what looked like some echo contrast, kind of not just swirling in the whole left ventricle, but more pooling kind of in the apex. So zoomed in over here, with some of the views at the time, it was hard to tell. Was that just pooling contrast, just poor apical movement in the setting of known heart failure, or severely reduced ejection fraction, or as many with severely reduced EF can have, especially if they've had, apical wall motion abnormalities. Could she have had an apical thrombus? So we had echocardiographer come down. He used contrast. Turned out she did not have a thrombus. It was just very poor sluggish flow at the apex. So this was not their IVC, but this is what it would look like. This is another patient, severe congestion, very large in short axis, very large IVC. You can also see that spontaneous echo contrast, incredible congestion. Every vein in his abdomen was just humongous. He had the biggest left renal vein on ultrasound I've ever seen. Um, so this was a patient we recently had a few months ago, new nephrotic syndrome. So 60-year-old diabetes, maybe CKD, poor access to care. So he was waiting to see a nephrologist, but someone had gotten, he had like 5 grams, 6 grams of protein in his urine. This was kind of painting this picture of nephrotic syndrome. He had a very large heart on chest x-ray. So first taking a look, now these aren't the best images. It looked like he had a little reduced ejection fraction here, but it was just kind of poor view. You can't see the endocardium that well. So he had relatively preserved ejection fraction. His didn't have any diastolic dysfunction. However, what he did have dysfunction of is fluid third spacing. So he had this pericardial effusion. You can see that over here on this apical view here. Um, and he also had pleural effusions. So it turns out these are all transudative. The pericardial effusion, it did get a little better. It was likely, talking with cardiology after we did a serologic assessment, he didn't have any sort of autoimmune disease. There's a concern for TB, kind of ruled out active TB. So we think this was probably pericardial effusion just in the setting of a nephrotic syndrome. He did not have tamponade, but in the setting of nephrotic syndrome, he had a lot of fluid that had to come off. We were aggressively diuresing, and so we were scanning every day when we initially started diuresing, so that we didn't take something that was not tamponade and kind of too rapidly diurese him and intravascularly and turn it into a tamponade. So that's where ultrasound serial assessments can really help. If you ask an echo tech to come in every day and do a limited assessment to assess for parameters of possible tamponade physiology, or come to every day to assess parameters for anything, they'll kind of look at you kind of strange, and that's inappropriate resource use. So this is where the point of care, the focused cardiac ultrasonography can really help. So next, this was actually a residency patient I had, mid-30s-year-old woman. She had newly been diagnosed with lupus, came in with 2 weeks of progressive dyspnea. She had an enlarged cardiac silhouette on X-ray. Of course, it was like 6 or 7 o'clock, and all the echo techs had gone home. So I went and put a probe on there, and she had a significant pericardial effusion. She also did not have tamponade physiology, and this was likely related to her lupus. So this was uh, this is one of those great finds we had. I was very proud of this in residency, finding this. And we also didn't have to call in an echo tech in the middle of the night. So this was actually a colleague's image. Middle-aged woman, maybe a little older age, 50s to 60s, came in with dyspnea, chest pain, tachycardia, new oxygen requirement. CT scan found a PE. So my colleague, one of our internal medicine ultrasound fellows, actually did a bedside assessment. This is the right ventricular inflow tract. We see a little guy jumping around here, this little goober, kind of twirling around, kind of jumping across the valve. It turns out that was a clot in transit. Um, uh, so on short axis here, you can see, and remember this patient had a PE. So what we're seeing here is normally this septum that is shared by the left and right ventricles, normally this is bowed into the right ventricle. But in this lady, she had significant pressure on that right ventricle from this PE. So all of a sudden it has a huge afterload increase. Its right heart is not used to that acutely. So what's happening is this septum in systole and diastole, it's actually flattening instead of being round and bowed into the right ventricle, it's more flattening towards the left ventricle. They call this the D sign. So instead of like a O here, having that septal flattening. So she had significant right heart strain. Here's an apical view just showing that clot in transit kind of bouncing across that tricuspid valve. Very large right heart. This is a right heart that is in trouble. Um, this is not something you want to see when someone already is kind of teetering on the brink of that high risk submassive with maybe not persistently hypotensive, but tachycardic, intermittently hypotensive. The PERT team actually came and saw them and said, especially they are already hemodynamically in trouble. And with this clot in transit, who knows if that's going to push them over the edge. So they actually push lytics at the bedside. This is just subcostal view showing that clot in transit. I do not have a follow-up echo for this, but about 12 hours later, so they did lytics, admitted her to the ICU. She did well on anticoag. About 12 hours later, cardiology, they had a cardiology echo. The right heart was no longer dilated. There was no more clot in transit, and she did very well. Uh, so where POCUS can help the most is in critical situations. And so in the hospital situation, where do we see that? Or for those of you who do critical care, you see this every day, but rapid responses is where I see a lot of this. So, someone who you're called for one of the most common causes of rapid responses would be respiratory failure or hemodynamic compromise, whether it's progressed to shock or not, depends. But so you'd approach someone, say with, they're tachycardic, short of breath on new oxygen, very differently with a relatively normal heart like over here than you would with someone like this, very depressed LV function here. However, at the same time, someone with, say, tachycardia and new oxygen requirement, one of the things you'd be worried about, and if they've been here forever, especially if you're not able to put them on anticoag, could they have a PE? So what we're seeing here, although the left heart is in trouble, this right heart geometry here, the right heart structure is relatively preserved. We see that septum bowed into the right side, relatively wedge or sail-shaped look at the right ventricle. So even if you can't do advanced Doppler or M mode or whatnot, get TAPS or whatever, do some of your right heart parameters. At the very least, one of the tenets of point of care ultrasound is you say you use what you can see. And right away, we can see, okay, at least it's not a big quote unquote blown out right heart, less likely something like a PE. Versus your approach to someone like down here who has a left and a right heart that is in real trouble, and you're going to approach, say, their tachycardia, developing hypotension very differently. So similar lung ultrasound here, you'd approach, respiratory failure or even tachycardia, need for fluids, not fluids, something very differently with someone with these A lines, very dry looking lung than you would with someone down here, the one we saw earlier with all these B lines diffusely indicating possible pulmonary edema versus someone over here. This is actually a still image. This is just showing lack of lung sliding. So past the pleura, that is a very relatively specific in the right clinical context for a pneumothorax. So that would be very nice to know. For instance, if you are respiratory failure, you can't get the X-ray in there. It's a small room, peri-intubation period. It'd be very nice to know if you're about to intubate a pneumothorax. This, you see oftentimes someone goes from being normal or relatively, compensated respiratory failure to deep compensated, really working hard. You either need to get BiPAP on as a bridge to intubation or intubate right away. You would rather not do either of those positive pressure options in someone with a pneumothorax. Maybe you would just need a needle in the chest. I've literally jumped on the bed several times as patients are going to the ICU. We don't want to stop, even in a peri-arrest situation. I've been called several times, either on my patients or other people's patients, and just take a quick look at the heart. And I said, well, let me just jump on the bed. I'll straddle the patient, ultrasound with the handheld as you're pushing both of us. And we can actually, because what do they need to do? They need to get to the ICU. They don't need me to stop and do an ultrasound right then. We would like to know, do they have a big PE? Do they have a, terrible EF at this point? They have pneumothorax, dissection, whatever, but they need to get to the ICU in a peri-arrest situation. So portable ultrasound riding on the patient's bed for the win. So, uh, it looks as far as time-wise here, it looks like okay, we're getting relatively close here. So I may just have to send some of these slides out, may have to breeze through some of these. Soft tissue ultrasound, it's a rising area in ultrasound. So this is actually something near and close to our hearts out here in Arizona, where you can see several. Usually, soft tissues ultrasound, it's used to see if there's abscess, if there's cellulitis. This person had several of those findings. Snake bites is one of these that we see out here. I just had my first of the season the other day. Fortunately, it was a dry bite. Um, this is a person who had come in, 80-year-old man, no significant history. Within about 2 hours ago, he was bitten by a 3-foot rattlesnake. Um, Images were taken kind of around the lower leg and an ankle. So we're kind of seeing the ankle joint here. What we're seeing is he has significant disorganization of the fluid up here. This is what's called cobblestoning. It's indicative of edema. Also, he's had significant ankle swelling and redness, and this is a limited view, but in further interrogation of the ankle, he did not have any sort of joint effusion. So that helped us a lot because with these snake bites, you can get significant local tissue destruction, and it can cause compartment syndrome. And the problem is they don't do too well if you fillet them and open up even in a compartment syndrome. For some reason, the snake bites, they do very badly. So this is interesting finding. So this is muscle in the lower leg, short axis and long axis over here. You'll see that shaking. That is not me pushing the probe. It's actually some fasciculations. Doing some research right now to see, because we know this, you can get this myokemia, just the chemical irritation from the venom of the local musculature. And doing some research right now through out here that's being run in the ED to see, if you can see the fasciculations on ultrasound, the kind of subclinical almost fasciculations, not visible with the naked eye, can this be prognostic and indicate a possible worsening prognosis over time? So, um, next, I'll have to send this out. This was someone who had diffuse large B-cell lymphoma, had recently had a lymph node biopsy in the groin, came in with spontaneous discharge redness where we didn't know if there was infection there, hemorrhage. You can see this is the area of biopsy. This is actually kind of a fluid level. Hypoechoic fluid here. You can see this layering, very thick fluid. It was most consistent with after image analysis. The cultures were negative. It looked like this was just a hematoma. And with the seroma part here, hematoma part that's layering the thicker, heavier blood on the bottom, and it was likely not an infected hematoma afterwards. But this was a neat soft tissue study. So soft tissue ultrasound, yes, cellulitis, abscess. It's more and more, lots of literature. Some of the most literature is on this in emergency medicine, but more and more being used in internal medicine realm. This is one of the favorite studies of all time. So as far as DVT ultrasound, Ernest Fisher and company made this study. This is one of those you can never use this name again for a study, but hocus pocus. I post this every Halloween. It was very appropriate that they actually published it in October in 2019. But this was a big one of the first big things to show that yes, we knew that emergency medicine critical care doctors could use DVT ultrasound to faithfully diagnose a DVT and accurately. This is one of the first ones to show that internal medicine could as well. So quick, just going around looking here. This is from the POCUS Atlas online. Short axis, we're seeing a clot here. Long axis, we're seeing this in the main femoral vein. This is a large thrombus, kind of almost moving. I've seen several of these or images of these where it's sometimes it looks like a little worm just kind of working its way up the vascular system. As Paul Mayo says, every PE was once a clot in transit. So these are one of these that we're really worried about that this could have gone on to cause that clot in transit we saw earlier. Also looking at upper vein, this was actually in residency, one that I was called a patient in the ICU had been there for a long time and was needing central access, maybe a vas cath, went to look at his right IJ, and lo and behold, he had already had a central line that previously had been removed, and there was this large thrombus. You can actually see this pulsating along with the venous pulsations reflecting right atrial pressure changes. So we said this would not be a good idea. You jam a line into that, you will create a clot in transit. So abdominal, we may have to move a little faster through here, but this is one case I like to talk about. So often in abdominal, we're using it to see, is there ascites? We're looking for hydronephrosis, also looking at bladder volume. That's a very high yield area. This was a patient who was a 60-year-old woman with cirrhosis, bad cirrhosis, terrible coagulopathy, had just downgraded from the ICU about 12 hours earlier. And rapid response is called the next morning for hypotension, tachycardia, had a lactate of like 8, and had a several point drop in hemoglobin. So we do the ultrasound in our abdomen. We are seeing, this is the right upper quadrant here. We're seeing this area of just this hyperechoic, kind of congealed, this globulated area in the setting of recent para and drop in hemoglobin. We're concerned that this was actually hematoma. Um, so CT actually corroborated this, just one of our arrow signs here, but this was you can see the hyperechoic fluid in several areas. This lady, she ended up, she just had overwhelming disease, bunch of complications. She ended up going hospice. This was a patient a lot of us actually became very close to, but he was also a cirrhotic, been recently diagnosed. He had just gotten a paracentesis. Rapid was called for tachycardia hypotension. I usually, I used to, in the setting of someone with ascites, I used to not do abdominal ultrasound in the setting of, tachycardia or shock, hemodynamic compromise, because I thought, well, if they have ascites, if there's new blood causing this, it's going to look the same echo density of ascites. But this actually really started changing my approach because right upper quadrant, we're seeing the liver here, and then almost looked like a hepatic vein in the beginning of the clip here. But the problem with that is it was way too far to the periphery to be a big hepatic vein. And also, this was a separate piece of tissue, not connected to the liver. You can see at the liver tip here, there is actually, we see this conglomerated. It turns out it was likely a hematoma from a relatively rapid bleed after the paracentesis. So either he had a liver laceration spontaneously, which did not happen, or we think this was likely hematoma. Turns out his hemoglobin point of care came back. It had dropped like 3 units since the morning. We got him down to the CT scanner. As soon as we got him on the bed, unfortunately, he went into VFib arrest. He did survive the arrest. So this is something, this was a patient I was actually doing an ultrasound on. You can see the parasternal subcostal notation here. But this is, right, so we're seeing left lobe of the liver here and the heart, and then this is actually his stomach, likely antrum here, going into the duodenum further on. But he had lots of, this is a very large antrum. He had lots of gastric content in here. So in someone who's a little altered, especially respiratory distress, and you see this, that you start getting very concerned about aspiration. I had a similar patient, and this is where it can kind of help palliatively. He was someone who was palliative care. He ended up, he was, we were treating him aggressively. It was a terrible cancer, just finally succumbed. He said, I just want to do hospice. We started him comfort care in the hospital. He was having significant nausea and vomiting. We put the ultrasound probe on and saw something even more impressive than this. He had just tremendous gastric distension, was not picked up on KUB because there was no real air, air fluid level. It was just lots of fluid. So what we did is we put an NG tube in, evacuated like 1.5 liters of fluid. He ended up dying about 12 hours later, but we made him much more comfortable. In the last hours of someone's life, you say, do I really want them to go out with an NG tube? Well, we could have kept giving Reglan, Zofran, whatever, but it turns out we said, you have a huge stomach here. Why don't we just try it and see if we can relieve you, and at least, he said, okay, we'll try it. If I don't like it, take it out. We put it in, and sure enough, we hit pay dirt. Just tons of fluid came out. He felt so much better, and he was able to, instead of just groaning and being miserable, he was able to talk more with his family for those last 12 hours of his life. So hydronephrosis, this is an impressive one I had in residency. Patient came in, I forgot what they came in for exactly, but they doing a renal ultrasound. He had I didn't see kidney at all. This is his left kidney. It was just lots of hydronephrosis. And you can see on the CT here that he had humongous collecting system dilation and very tortuous ureter here. So some of these other, we're getting very close to the time, I think. So I'll have to send this out. Ocular ultrasound. This is becoming big in medicine. You can see this was a patient we had decreased, we had admitted him for cellulitis, but he also had worsening right-sided vision. Turns out later we found out he had a known retinal detachment, but he had actually over the past month, he had lost vision completely. So this is showing significant membranes here in the eye. You should not see anything in this posterior chamber except hypoechoic black fluid. So we had significant membranes here. This was indicating a retinal and vitreous detachment. musculoskeletal ultrasound. Thanks, Mark, for these pictures. There's actually some sonoscanner machines being used at a workshop, I think, at AIUM. This is something that has been very developed actually at bedside by rheumatologists, sports medicine, um, and a lot going on in the field. Um, so one of the most common things we get called about in medicine, patient has a Foley or no Foley, but has urinary retention. This was actually a patient who came in with hematuria. He had a Foley in, and then all of a sudden stopped making urine. Looking at his bladder here, and then you can see it in short axis. Um, there is here is the Foley balloon. And so he should be draining. So we see a little Foley balloon, a little bit of the balloon poking out, but there's a lot of fluid in there. This should all be collapsed around the Foley. So it turns out it was because he had significant clot forming. So we actually just flushed the catheter. We were able to declot it. It worked a little while and then happened again. So we actually had to get urology to go in and kind of, they put in a continuous bladder irrigation just to evacuate all that out. So, one of the funnest things to do in ultrasound is actually to teach procedures. We like to start on simulation instead of going straight into patients at the bedside. So this is very fun to do. Um, uh, the procedural, I'll have to send these slides out, and hopefully in a future webinar, hopefully we're going to actually go delve more into pearls and pitfalls for procedures. But this is where there is a lot of evidence for internal medicine use of ultrasound for image-guided thoras, paras, LPs, lines. So, and I'll see if we can actually just get these slides sent out. Um, so. This is actually a good case. We were called to do a paracentesis on this patient, and we put the probe on, and he had known metastatic cancer, new ascites, and lots of these. This is the peritoneum here. This is bowel down here, but lots of peritoneal implants, and a lot of these little circles you're seeing. That's actually in short axis. When we put color on those are all vessels, and so you want to be very careful putting a needle in anywhere near one of these implants that can definitely bleed. So. Um, Training, there's several opportunities. If you reach out to me, email, or you can find these online. But there are in-person courses, curriculums, longitudinal curriculums now through TREST, HCM, ACP, ultrasound fellowships. There's more and more teaching in residencies. Um, here's a slide. One of the biggest problems we have with barriers to adoption in ultrasound is that we need the financial case for it. So this is some great stuff to bring to administration to say, look, we're reducing readmission. An interesting thing some geriatricians found out, quadriceps muscle thickness to predict length of stay, and likely as part of predicting frailty, in which case predicting increased length of stay in older patients. So. Sorry, we had to really kind of rush things at the end there. I don't know if we have much time for questions, but thank you very much. And I hope you enjoyed it. If you got bored, I hope you had a decent nap. And
Actually, I think that was a wonderful presentation. Thank you, Dr. Coe. And you can always tell when somebody is very much into their work and cares about what they're doing and cares about their patients. And for sure, we were able to see that today as you were discussing many of the slides. So, with that, let's open it up for questions and answers. Jean, do we have some questions in the queue for us?
No, not yet.
Okay.
oh, excellent. Got it. So I just either wowed everyone or put everyone to sleep. So that is good. And then this is my contact information too. If you want to reach out at all, probably email is the best. Yeah. So.
Yeah, if anybody was wondering how to ask a question, by the way, in the lower right-hand side of the Zoom screen, there's a Q&A button. If you can't see the Q&A button, there's three little dots next to each other. Click on that, and then you'll be able to see the
Yeah,
Q&A.
and we have our first question from Dr. Powell, who is asking, can you use ultrasound to detect compartment syndrome in the snakebite case you mentioned?
Yeah. So actually, very good question. I guess compartment syndrome, like many, is a clinical diagnosis. Um, compartment syndrome being, critical outflow obstruction, then inflow obstruction, and ischemia to the tissue. Could you see death of tissue? You probably could with ultrasound. You would see just maybe, I don't know if anyone's looked into this, probably have Usually you will see this clinically much faster, and here they're really quick to put the striker needles in to actually test compartment pressures as soon as you start losing pulses. But yes, actually, if you could email me that question with your email, I'll try and get back to you, Dr. Powell. I think that there is some stuff on that somewhere on using ultrasound. But yeah, could you, follow, say, do vascular ultrasound and assess, venous flow or at least arterial flow, maybe strength of the pulse. You probably could. Usually, you're going to see this clinically, just visually, a lot sooner. But
I knew the snakebite scans would gain some interest, right?
oh
Because
yeah,
I think that's pretty unique. And of course, you're seeing that there in the Tucson area for sure.
oh yes, yes, yeah. Whenever I take my trash out, I always use a flashlight and I look very carefully, even though my landlord says, "Oh, they're not in the snakes aren't in your area of the town." I say, "Well, what if they didn't read the book?" So
And I think we're done with the question.
got it.
Great.
All right. Well, hey, thank you all very much, and hope to see you in the future. So.
Thanks to everybody.